hello everyone. Welcome to this session entitled Structural Heart Disease Live Case Session 2, TAVR. And I'm Kentaro Hayashida from Tokyo, Japan, co-chairing this session with Professor Jian Wan from China. And I also would like to introduce distinguished panelists, Dr. Case Allen, and Dr. Philip Blanket, and Dr. Anthony Wan. So today, we're going to have the live demonstration from the Serious Hand Medical Center. So Dr. Raj Makka. Hello, Raj.
Yeah, hello, Kentaro, can you hear us?
Yes, perfect.
Okay, lovely. It's great to be doing this live transmission to the TCTAP Asia Pacific meeting. It's one of my favorite meetings. Hopefully we'll be there in person sometime soon. And I want to thank the organizers as well. So what we have is we have a couple of cases for you today, and we are going to start with a bicuspid TAVR case, and then we will move on to the other room where we intend to show you a mitral valve-in-valve case using the SAPIEN valve. So let me go ahead and introduce our team here. Everybody's excited. Everybody wanted to be in the case. Normally when we are doing these cases, there's just 2 or 3 people, but you know, this is Dr. Wencheng, my colleague surgeon, and this is Akriti, our senior interventional fellow. Everybody knows Mamu Nakamura, who's worked with me, and we have Liz, and we have Michael prepping the valve, and Tejas, and also we have some excellent techs in our control room. So Ahmed is going to go ahead. He's our interventional fellow, and he's actually going to go ahead and present our case. And I must not forget that Moody is our anesthesiologist, and he'll also be going ahead and actually going over the echo findings. So Ahmed, please go ahead and present the case.
Thank you, Raj. I'm going to present the case. This is a 77-year-old female presented to the clinic with a progressive shortness of breath with the significant limitation of her daily activities. She's only able to take only 1 flight of stairs. Her past medical history significant for breast cancer. She had a lot of radiation to the chest. Next. This is the transthoracic echo, and we see there's a lot of calcified aortic valve, normal LV function, and then the mean pressure across the aortic valve is 58. Next. This is on CT, and we can see it's a type 0 bicuspid aortic valve. Next. I'm going to give you a little bit of maybe 15 seconds just to look at the measurements of the annular valve area of 448. The LVOT is 407. STJs, as you can see here, the SOV and then the ascending aorta is not that big. Next. The coronary heights are acceptable, so no protection needed. Next. This is our angle for deployment, the LAO of 19, total of 13. Next. The iliofemoral anatomy is amenable for a transfemoral approach. We chose to go through the right femoral artery. Next. This is the aortic arch anatomy, and it looks suitable for a cerebral protection device that we're going to use in this case. Next. So in summary, this is a severe symptomatic aortic stenosis of type 0, bicuspid aortic valve. The plan for this patient to go ahead with a transcatheter aortic valve replacement, 26 millimeter SAPIEN 3 Ultra valve. And then we're going to use the cerebral protection device using the sentinel device.
Thank you very much, Ahmed. So before we go on and ask Moody to show us the echo, I think what I like about the case here is that the coronaries are actually quite high. In fact, they're almost 20, both for the left vein and for the right coronary artery. So as we plan this procedure for this patient, I think it is very clear that this patient should be able to have a TAVR procedure, you know, down the line, maybe 8 years, 10 years, hopefully maybe longer, or who knows if it is needed earlier, very safely. So I think that's something that's really good. It's a type 0. Now, there is a fair amount of calcium, as we will actually show you fluoroscopically. There are no calcified, raphe here, since this is actually type 0. There was a little bit of calcium in the LVOT. We didn't get to see that. The LVOT is a little bit narrower compared to the annulus itself, but I think that the 26 millimeter valve should actually serve our purpose. The intercommissural distance is almost 26, so which tells us that I think that's another measurement that we need to be careful about or keep in mind as we do these bicuspid cases. So I think a 26 should match up with this. The other thing that is good about this case is that the aorta is not that enlarged. So I think, that also keeps this somewhat non-controversial. So let's go to, Moody and ask Moody to go over the echo findings. And then, of course, feel free to ask any questions after that. Moody?
Thank you, Raj. Thank you, everybody. So this is the long axis view of the aortic valve, and we explaining that to get the short axis view, and you can see it very clearly here. It's a type 0. We don't see any raphe here at all, and it's very heavily calcified. When we're measuring the com-to-com distance here, it's 26 centimeters, 0.4. So that's kind of, again, correlating with the CT scan. There's no surprises here. The only thing surprises that we see here is that there's a lot of calcium, and even it's extending into the anterior mitral leaflet, as you can see here. And we can show you also the 3D view of the valve here that will be showing the calcium protruding into the area of the valve. This view here. So as you can see here, there's a huge chunk of calcium. It's correlating with this one here. And this is here how it looks like on the 3D view. You can see the surgical view here. You can see how it's correlating there. So yeah, it's and then we got the CT and the measurement here of the valve area, and it's 491. Again, correlating with whatever the CT scan is showing to.
All right, so thank you so much, Moody. So Kentaro or Professor Wong, do you have any questions? As you are doing this, as you can see, I'm advancing the Sentinel device. Where is our wire? Let's put the
wire is in.
Okay, good. Out. All right, so we are just going to go ahead and can you give me a little tension, please? All right, terrific. Okay, all right. So the calcium is heavy, and so for bicuspids. It used to be that, using embolic protection was standard of care for us for every single TAVR. We recently enrolled 350 patients in the protected TAVR study, which is a randomized comparison, and we are waiting for the results of that. But in this case, given that it is bicuspid, given that there may be somewhat increased risk of stroke in these patients, we thought that it was actually very reasonable to go ahead and use embolic protection device. Okay, all right. So we've deployed the first filter, as you can see, in the brachiocephalic. Now we will actually come back and try to, can we, Mamu, bring this wire back? Let's see. We will go ahead and deploy the next filter. All right, can you bring the probe back, please, Moody?
Okay.
All right, let's see. A little bit back more, please.
Okay. Back more.
All right. Okay, so we've advanced the wire up into the carotid. Now we will advance this a little bit further and go ahead and deploy the next filter. So both filters are now deployed. So we will make sure that the device is snug with the aorta, so that we do not interact. So we'll just advance the pigtail catheter, and actually that nicely showed. For the purpose of teaching here, let's just go ahead and take a picture here so that, all right. All right, okay, so this is fine. Now we'll go ahead and take our pigtail catheter and put it down into the coronary sinus wall. Okay, terrific. So let's go ahead and secure this, please. So we have a protocol of going ahead and actually using this Tegaderm to fix this. We will cover this up also with a towel so that we do not pull this or accidentally remove it. Okay. Now, Are there any questions that we can address from you guys about the case? What do you think? Do you think that TAVR is a reasonable option here?
Thank you very much, Raj, for your beautiful presentation and the demonstration. And how often do you protect do you perform cerebral protection usually?
So, for about 2,000 cases, we used embolic protection in every single patient. Then from the TVT analysis, what we observed was that the stroke rates were only very modestly reduced. So we chose the approach of enrolling all of our patients or most of our patients, as a first strategy, in the protected TAVR study. So the protected TAVR study is now finished enrolling. It's a large study, 3,000 patient study, and I think those results are going to be extremely important in telling us whether or not we should be using this device in patients. Because in the TVT registry, when you look at the data, that the embolic protection device was used only about 15% of the times overall. But you just saw this, so you saw the demonstration. So yes, there is cost associated, but if the anatomy is favorable, you saw it took us only about 3 minutes to actually, to put this device. We feel that when you have a heavily calcified valve, or a bicuspid valve, I think you must have very low threshold to go ahead and use this.
Professor Wang,
Okay.
Do you have any comment?
Hi, hi, Raj. Several questions.
Yes.
The first question is about how do you make a decision the size of the 26? So what do you think
Yes.
about how to prevent the atrial ventricular block for this kind of patient with severe calcification?
Yes. So I think if you look at the annulus measurements, they fall in range for 26 for both. They were both, what was the annulus by CT? Remind me?
24.
480.
Yes. So I think that, and yeah, the LVOT is a little bit smaller, but we want to try and land this valve not too low, and so I think, and the intercommissural distance is 26. So I have a feeling that, either we have to go low so that we seal in the LVOT, or we actually, go relatively at a decent height. Because I think when you have PV leak with this amount of calcium, I think it is not very pleasant. So we will be safe. And I think Dr. Wen Cheng, who, takes the inflation device up, is a very experienced person. So there are times we will actually inflate and deploy the valve in 2 stages. If we meet a lot of resistance, he may leave 2 cc's back. We will reassess everything by echo, make sure that it is safe to go ahead and empty it. So I think those are some of the factors. I think it is reasonably in the range of 26 here.
What do you think about cuspal overlap technique? So can you, for this kind of patient, do you think it's still?
No, I have to say that I am not for balloon expandable valve. I personally do not see, I know some people do, I don't see a big necessity for a cusp overlap technique. And I think it becomes even more complex with bicuspid aortic valve, especially with type 2.0. I think we can generally do a very reasonable job, in following the traditional views and methods while deploying the stent. Okay, so look at the hemodynamics. Yeah, while you gather your thoughts, but I just wanted to point out the hemodynamics before you. There is a very robust gradient here. The gradient is 57. The calcium is heavy. Normally, we are not big fans of pre-dilating unless you really need to. But in this case, I think it may be a reasonable thing to pre-dilate before we actually deploy the stent. What do you think, Mamu?
I think that's reasonable.
Do you guys agree that would you pre-dilate this?
What do you think?
Yes.
Yep. Yeah, yes, please. Yep, I agree.
Yeah. Okay. All right. And then I'm sorry, you were saying something, and I was speaking at that time. So Please feel free to, yes.
I see your little cheat sheet with the LA019 view on the plexiglass there. What view? How do you choose your view for type 0 bicuspid valve?
It's the same, our core lab will basically, give those to us. So I don't think they have anything special for bicuspid, but Philip, is there something different that you do? Tell us.
No. Just like carrying Dr. Wang's thought in terms of cusp overlap view, because you only have those two hinge points as orientation. Yeah. So I was just like curious which point you took on that optimal.
Like 16 or 20 about.
All right, so we'll take a 20 millimeter balloon.
Okay.
Let's do so.
And Raj, so could you please tell us which type of catheter did you use to cross the aortic valve? Because you crossed the aortic valve very quickly, and
Yes.
it was so impressive.
Yeah, I think we got lucky, but typically I use an AL1 catheter and I use a straight wire, a 30, 35 or a 38, 38 actually. I think 38 is a little bit more stiff. So that is what we will actually use. So we are using this balloon. It's a 20 millimeter balloon. It comes with the Edwards kit. So we want to, it comes free. So we are going to go ahead and use that rather than, so it's a little bit shorter balloon, but nonetheless, I think it serves the purpose here. Okay. All right. So is our pacemaker ready, Lisa? Okay. All right. Can you go ahead and pacer on, please? Okay. Let's go up, please. Off, please. All right. Moody, can you work with your probe a little bit? It is right on top of our valve. Okay. So we did dilate. See if there is some AI. Our pressure is a little soft. Okay, so I think maybe we have quite a bit of AI. So let's see if it is still there after we remove the balloon. So it's not that bad.
No, it's not bad here.
Okay.
And pressure recovery.
All right. I think what we forgot to show you is it is now very common for us not to have an angiogram done at another time, but we do the angiogram at the time of the TAVR procedure. Since COVID, it is hard to get patients back in for multiple procedures. So, this patient's coronaries were done. There is no significant coronary arteries. You can also see the calcium there in the aortic valve, which is actually not trivial. In fact, this looks a lot more impressive than the 4D CT images that I saw. So I think, which tells you, that you can play with the settings on 4D and you can make either look more or less. Okay, so we will go ahead and we will advance the device. All right. Okay, so let's go. Yes.
So do you usually use smaller balloon for the bicuspid valve?
Yeah, I see no reason. The only reason to do pre-dilatation is not to struggle while crossing with the valve. We just want to create enough room and not overdo it. So we've been using, the goal is never to go above the minimum MLD, the minimum diameter of the annulus, but even smaller. I think a 20 millimeter balloon is most of the times adequate, we feel, so that we don't struggle. All right.
Hi, Roger. Do you regularly perform the TE for this kind of patient?
So for bicuspids, we have taken the approach right now, that for bicuspids, we want to gather a lot of data. We want to learn. So we are doing follow-up CTs, we are doing TEs, and I think that, so we tend to do that for complex cases, and we'll tend to do for bicuspid cases because we still want to gather some useful data. Test, please. And, since the aortic root injury, a lot of the bicuspids that we do are a little bit more complex, and aortic root injury, is uncommon, right? Like we showed in our recent analysis from the TVT registry, but it does occur. Test, please. Okay, So is this our view, guys?
Yes.
Okay. What do you think? Do you think that we should go a little bit lower, or we'll just try to keep it there? Ben, what do you think? Test, please.
Should be a little bit lower.
Okay.
This
Maybe too
is
high.
A little lower? Okay. All right. That's exactly what Wen actually said, but I think now we are a little too deep. Test, please.
I think loosen line should be okay for this case.
Yeah. Okay. Test, please. Yeah. I'll keep it there. All right. Okay. All right. So our pressure is a little soft, guys. Are you ready with the pacemaker? Okay. All right.
Ready.
Everyone?
Yeah.
Okay. Pacemaker on, please. Inject, please. Yeah. Let's go up. Down. Off, please. All right. Okay, so what Wen just told me is that he deployed it with -1 cc's, and you can see that our view was not perfect, right? Because when we deployed, the valve was not a rectangular. Can you, okay, terrific. All right. So our pressure is a little soft, please. Moody, would you like to?
Please faster a little bit.
Can you pace? Can you go ahead and pace the heart at about 100, please?
Okay.
All right.
Sitting now back.
Okay, so that's good. I think it needs a little time to equilibrate. All right. All right. So you can see that our valve is not fully, when you look at it fluoroscopically, you can see that it needs to be stretched out a little bit, right? You can see that it is not as much, when you look at the dimensions side by side, that the valve is not fully expanded. So when I'm thinking that we might need to stretch this a little bit. And we see this, especially in bicuspid aortic valves or heavily calcified valves. The valve may not, there may be some recoil. And in fact, when you do a second inflation, even if it is with the same volume, the valve comes up a little bit better. So do you guys, there was this spicule of calcium that Moody was showing us earlier. Moody, is that poking out?
Still the same here,
Okay.
as you can see.
All right. Okay. So our pressure is a little high now, Moody, after you treated.
Okay.
So maybe we need to come down a little bit.
Or bring it down a little bit more.
Okay. So the good thing is we are back in sinus rhythm. All right. I think, and we are not bradycardic. So I think, it's.
So, Raj, so how much PVL do you have now?
Okay, so go ahead and, can you go ahead and.
Showing the PVL here. Yeah.
Okay, so show them the PVL. Yeah.
Actually, there's nothing there.
Okay, so there is not very, very trivial. But I'm not satisfied with the way the valve has expanded fluoroscopically. So I am very much in favor of doing another post-dilatation and stretching this out. I feel secure about doing so also because we have a sentinel device in place. So we know, all of us know that, post-dilating slightly increases the risk of stroke, but here in this case, we do have that. And I think that's another reason why in bicuspids that are heavily calcified, it makes sense to actually use embolic protection device. So let's, Wen, do you agree? Okay, the pressure is still high, so let's bring the pressure down a little bit, please, to like 170 or so. All right?
It should be coming down slowly.
Yeah.
Huh?
Okay.
So
Any
Raj,
other? Yes.
Raj, are you also thinking about the long-term durability of the bioprosthesis?
That's correct. I think we all know that there may be consequences, right, of under deployment. It's possible that that may affect valve durability. So I think that to the point, I think we have to balance all of these different things, right? So we can't overdo it. But as you can see on the echo there, if you look at the coaptation of the two leaflets, okay, there is quite a bit of height over which they actually coapt, suggesting that maybe we need to go ahead and work a little bit more to expand the stent. And we have to balance, we cannot overdo it and have aortic root injury, but at the same time, we'll do so.
Okay. And the expansion could also associate with the injury of the bioprosthesis, so it's reasonable to perform the post-dilatation.
Yeah, yes. Okay, Moody, are you okay?
Yeah,
You're going to go ahead and
I think the pressure is not going to be around 170 now.
Okay. All right.
Dr. An, this is Anthony from Hong Kong. So are you going to add back the 1 cc volume for the post-dilatation?
So, we'll see how it looks, right? I think a lot of times, even when we give the same volume the second time, it will actually probe. Can you bring the probe back, please? Okay, that's good. All right. Even when you give the same amount of volume, the expansion is better. So we will see, and Ben is going to feel how much resistance he gets. Okay. So it's a little bit of a judgment call. Okay. All right. Ready? Pacer on, please. It is not capturing yet. Okay, so let me wait. All right, can you go down by 10 beats, please? Stop pacing. Go by. Okay, stop. Now it started to pace. So just go down by 10 beats, okay, because otherwise the cine run will run out and will be dark. Okay, go to 170 instead of 180 or 160, whatever it is. Okay, all right, ready? Pacer on, please. All right. Okay, all right, let's go up. All right, see that it's now more expanded. Down, off, please. All right. Okay, so you saw it expand, and then you also saw it recoil, and I think it's still -1. Okay, and I think this may be also, we tend to see this a little bit more often in type 0 bicuspids. So I think I would say that there is 0 AI. Or Moody, why don't you tell us how much?
Yeah, so we're looking here for any PVL. There is nothing that we see at all. It's a very good. And the coaptation length of the leaflet, we measured, it was about 10 millimeter before. Right now, it could be down to 8 millimeters.
Yeah. Okay.
So I think it expanded just a teeny bit.
Okay, so I think that maybe there is no AI. We'll measure the gradients, and then I'm not keen to do any more post dilatations at this point.
Fantastic result.
Okay, so
wonderful procedure.
yeah, so we'll go ahead.
So why do you
gradient.
select balloon expandable device but not self-expanding?
I think that I think with bicuspids, it is important to get comfortable with one device. The results are also excellent with the Evolute valve, and of course, I've seen some data that you have shown from China with the use of the venous valve. I think it is a question of being comfortable. If you are intimate with one device and experienced with one device, to maximize that. But I have to say that I am equally convinced by the outcomes of self-expanding valves. At least the published data, though that has not been our experience. Our experience has mostly been in the in the balloon expandable. So I'm going to go ahead now and remove, while we are getting the gradients, so you can look at the gradients there. There is practically no gradient. We will go ahead and remove the filter. So I pulled back this filter. You can point to my hands, and now I'm going to advance it, unflex it, while Mamu will advance the wire so that we can safely advance this here. Now I will go ahead and resheath this filter. Okay, so what I'm doing is I'm advancing the sheath over this filter. Okay, all right, and then we will pull it out as a unit. So the Sentinel device is out. Okay, terrific. So what we will do now is we are going to move to the other room as we close up here. So we'll meet you in the other room. Any other questions about this case?
Okay.
Hi.
Okay, so thank you very much for your beautiful presentation, Raj. Congratulations.
Okay, terrific. Thank you very much. We'll see you in the other room.
Wonderful procedure.
Okay, good evening, everyone. I'm Tarun Chakravarti, one of Dr. Makar's associates, and I'll do the introduction while Raj walks over to the room and we get started. So on my right-hand side is Drew, one of our interventional cardiology fellows. Arvind and Jubin are our senior interventional cardiology fellows. We have the staff, Kylene, Cindy, Dennis, and Nancy, and we have Dr. Nawab Khawe from anesthesia supporting the case at this hour, and Dr. Sabah Skaf from echo, who'll be doing the echo and assisting us with the procedure. And as Raj is walking in, I can show you what we have done so far.
Okay.
So we went ahead and we
just ask the case.
So this is a case of mitral valve and valve. And yeah, actually, let's get started with the presentation first. So can you pull up the slides, please?
Yes.
Good evening, everyone. For our second case, we have the opportunity to present a 71-year-old male who presented to us initially with the chief complaint of progressive dyspnea. He had symptoms consistent with New York Heart Association Class 3 symptoms, and more importantly, he had recurrent heart failure admissions, most recently being last month of this year. In terms of his past medical history, no previous MI, PCI, or CABG, but he does have a significant valvular history, where he initially had severe mitral regurgitation that was fixed with a surgical mitral valve repair, which subsequently failed and led to a second operation in 2009, where he had surgical mitral valve replacement with a 29mm mosaic mitral valve, in addition to having a tricuspid valve annuloplasty and left atrial appendage ligation. Next slide. Additional medical history for him: he does have a history of hypertension, non-ischemic dilated cardiomyopathy with a notable ejection fraction of about 15 to 20%. That led to his ICD placement. Also has atrial fibrillation, cirrhosis, and interstitial lung disease. Next slide. Here we have pictures of the pre-procedure transthoracic echocardiogram, which was notable for moderate severe mitral regurgitation, and then also reduced LV systolic function, which you see here on the right. Next slide. Here we have some images of the transesophageal echocardiogram as well, demonstrating moderate to severe MR, but I think we will also cut to Dr. Skaf here. We'll show us some live intraprocedural images too as well. So Dr. Skaf, can you help with that?
Yes, thank you, Andrew. Could everyone hear me? So as you see here, patient has severe biventricular dysfunction as described earlier. This is a view of the bioprosthetic mitral valve. Notice that the valve is well seated. There's no rocking motion, but what you're seeing is exaggerated leaflet motion with some central mitral regurgitation. So obviously we'll also be looking to see, make sure that the valve is not dehisced and there's no paravalvular leak. And as you go up in the angle, you really notice that most of the leak is coming from the central, it's coming through the valve and nothing around the valve. And as I go up to higher angles, we'll be able to understand a little bit more why, the mechanism of this MR. So it really looks like it's a flail of the posterolateral cusp of the bioprosthetic leaflet with a very eccentric MR jet. So the MR here is very significant, and it kind of hides, and you really have to look at it really well in multiple angles to really see that it's really a jet that really bifurcates, and it's quite severe. This is a view of the valve on 3D, and again, notice this is the scallop that is flail, and you could really see it here on the 3D. And when you add color, it becomes even more apparent. And this is the splitting jet that you're seeing. It's all coming from inside the valve. So there's no paravalvular leak. What we're seeing here is like significant valvular regurgitation secondary to bioprosthetic degenerative disease. And if you look at the valve size, and you could really size the valve on 3D just like you can on CT, and the inner to inner sizing here looks it's about 23.5 by 23.7. And going on to the rest of the echo, I just wanted to show you a view of the transgastric view, looking at the mitral valve and looking at that mitral aortic continuity and aortic valve angle. So as you see here, there's a lot of space. I'm not really concerned. And as you add color, you could notice that there's no flow acceleration. What you're seeing is a bit of aortic regurgitation. And as we pulse through it, we see that there's no gradient. So there's no LVOT issue from what I'm saying. And I think we'll go next to your CT.
Okay, terrific. So let's let's look at the CT images as a part of the planning, right? So go ahead, Andrew.
So just as Dr. McCarr mentioned, all of our patients will get a CT prior to the TMVR procedure. Here we see that we had a predicted neo-LVOT area of over 1,300, and this is for a 26mm valve predicted, which is on the left side of the screen. utilizing our mitral valve and valve app, which helps to identify the true ID or inner diameter of this surgical valve, which showed that it was a 24 millimeter ID. It did go ahead and recommend that a 24 Sapien S3 valve would be best for doing a TMVR procedure. Next slide.
26, yes.
26, yes. And so in terms of the clinical indication, we do have severe symptomatic MR in this surgical valve. And our plan today is to do a transeptal mitral valve and valve procedure using the 26 millimeter Sapien S3 Ultra.
All right. So, so this is a very sick patient, right? The EF is very low, right? Saba?
Yes, very low.
Very low. The RV is bad. And how much tricuspid regurgitation is present?
Moderate to severe.
Right. So I think that is also an important issue when you're doing a mitral valve in valve, because a lot of times after you're done with the procedure, there is shunting because of tricuspid regurg, and you will have to deal with the hypoxia that may result from this, right? Okay, so we wanted to ask Huh? Oh, okay, so we want to ask the panel, you know, Kentaro or Professor Wong, do you have any questions about the case, or any of the panelists? You know.
Actually, I personally I don't have much experience about the valve in valve plantation, but I just ask you,
Yes.
where you do the balloon valvectomy first, try to crack the ring, surgical ring.
No, you know, I think this is a very sick patient, and then I think when you are trying to crack rings,
Camera is there.
oh, okay. So, and when you're trying to crack the ring, you're going to need long pacing runs. So that's not in our plan today, at least. Okay, our plan is to safely implant a valve inside of this valve and eliminate mitral regurgitation, continue aggressive diuresis and medical treatment so that we can actually get some fluid out of him and hopefully reduce tricuspid regurgitation as well. If the TR continues to be severe during follow-up, then what we might do is actually consider this patient for either a clip procedure, or in fact for one of the dedicated valves like the Evoke valve or the Intrepid valve. You know, we have all of those protocols that are ongoing at our institution. So that is what we intend to do. So obviously, you know, we do this procedure using the transvenous transeptal approach. And what I wanted to show you is the transeptal system that we use. All right. So there is this Baylis transeptal system using the it's called the VersaCross, or the VersaCross system, with a wire that is pre-shaped. So you can go ahead and you can change the shape here, right? So I think, you know, if the RA is large, so that you can make proper contact with the septum, you can give a bigger curve. But the important thing is that the wire that you use through this, the pre-shaped wire, so you use radio frequency to puncture the septum. But then that wire is strong enough that you can do a lot of work over the wire. So if you, for example, were doing a MitraClip procedure, you could introduce the MitraClip guide over that. If you're doing a left atrial appendage occluder, so you don't need to do exchanges. So that's why, you know, we really love this transeptal system, all right? So what we did earlier was, and what Tarun has done is recorded this, as you can see. Can you also show the transeptal echo images? Yes. Right? You know, so the goal here is to be inferior or mid, but somewhat posterior. Okay, you cannot be too high when you do a transeptal puncture, and you cannot be too anterior, because then the trajectory across the septum, across the mitral valve, is going to be a lot more challenging. So you can look at the echo, as Saba is pointing out with the cursor. Okay, so we have the bicable view and the short axis view, and we can see that there is tenting, and the tenting is actually posterior, and the tenting is mid-septum to slightly inferior to the mid. And on the fluoroscopy, you can see what we are doing. So we are tenting there, then we will say give current, and as soon as the current is given, we will go ahead and advance this wire without hesitating, all right? And it will go into the left atrium. So this is a very remarkable advance and great tool to do transeptal puncture. So now we've done this. So we have a wire now. So what we will do is we want to cross the we will go and we will advance this. So go ahead, Tarun. So we will advance. Tarun is going to advance the Agilis catheter. All right, please go ahead. Okay, all right. So we are now across the septum. I'm going to hold the dilator. Now, also you can see that fluoroscopy, those 3 markers that you see are the markers on the lower end of the posts of the bioprosthetic valve. Okay, so we are in the left atrium. We're going to take this wire out. We're going to take the dilator out. Now our goal is we're going to ask Saba to help us cross this valve. So what we are doing now is, as you can look at my hands, we're going to flex this, okay? And you can see the 3 markers there that roughly gives us some fluoroscopic guidance. But Saba will give us, you saw those beautiful images earlier that Saba showed. So you can see the valve now. All right, the bioprosthetic valve. You can see the Agilis catheter over this. So we will go ahead now and use the pigtail catheter and cross into the left ventricle. Then what we have to do is, have we done any hemodynamics? So we
measured LV,
okay,
LV LA pressure.
Okay.
LV AO we have not.
Okay, all right. So
let me just flush this once it's not
okay,
flushed.
so go ahead and flush this, please. Now, did we record? Let's go ahead and actually measure the left atrial pressure again. So
we have a tracing.
Where is the tracing?
Can you pull up LA pressure tracing?
All right, or
maybe we can just go live.
Actually, if you want. Okay.
So, this one.
All right. So I think we like to collect hemodynamics. It's nice teaching. Let's see.
Can you go to 50 scale, please?
So you can, just look at the left atrial pressure there. Okay, so this is the left atrial pressure. You can see the huge V waves there, right? In some cases, they go all the way up to 70. Okay, most of the times they're at least 50. All right. So, okay, we will now go ahead. In cases of stenosis, we will also go ahead and actually measure the gradients LV, LA to see, what the gradient is. Okay, so the Agilis catheter is going to help us. Okay, Saba, we want your help. Tell us where we should look.
All right, so you're very close to the opening of the valve. So
okay,
you're like quite.
So it seems like we're in the left ventricle.
You're true. Yeah.
All right. So we crossed into the left ventricle.
You want to measure
LVAO?
Yeah.
So what we can do is, because we have the Agilis in the left atrium and we have this, we can actually also go ahead and do simultaneous measurements of LV and LA pressure. So let's go ahead and show that. Okay. So this is the LV.
This is LVAO first.
Okay, so
LVOT gradient.
Okay, so we are showing you LV and AO. So there is no LVOT gradient at baseline. All right. Okay. Now let's go ahead and do the LV, LA pressure, and let's go ahead and show that.
Okay.
50 scale.
All right. So there doesn't appear to be at the end of diastole much gradient, right? So this is predominantly a problem of regurgitation than of stenosis. All right.
Agreed.
Okay. All right. So the next steps involved. This is the extra small safari wire, and we will go ahead and advance this wire into the LV. And what we have done is we have put the 16 French sheath here. Okay. The Edwards sheath for the sapien valve. Now you can use other balloon expandable valves also. So, I think there are other balloon expandable valves, and there is a little bit of experience, but of course, most experience is with the sapien valve. All right.
Raj, you make a carve on the safari wire?
Yes. Okay. So our safari wire is there now. All right. So what we will do is we'll take this out, the pigtail catheter out. Mamu, please take the pigtail catheter out. All right. And then we will dilate the septum. So one of the challenges that may occur in patients who've had prior surgery is that the surgeons might repair the septum or a patch on the septum. And then, crossing with the valve becomes difficult. So what we are going to do is, we are going to go ahead, even if there is we want to dilate it with the 12 millimeters. We've done some cases with 10, and you can get away occasionally. And rarely you require a 14 millimeter, but typically a 12 millimeter is adequate. So you can see our wire path, right, through the Agilis catheter, across the valve into the LV apex. All right. So we will advance the 12 millimeter balloon through the Agilis catheter, okay, and we will dilate the septum. Okay, where is the, okay.
So you're there.
Yeah, all right. So we will go ahead and, yeah, good point, Tarun, that you have to unflex because you don't want to tear the septum. So when you are moving catheters across the septum, if you have flexion, it is important to take the flexion off because you don't want to hook the septum and tear it occasionally. All right, let's see. Are we across the septum? Or
yes.
Are we? Okay, all right. Let's go up, please. All right, so I think we see the waist, huh?
Yes, very clear.
Yes, so we are now, yes, let's go up. Okay, so you see that, okay, all right. Let's go up and stay up. So this is an important step of the procedure because we've, early on in our experience, we've had to, if you get stuck here, then you have to come out, redilate. So I think a little bit of patience is not unreasonable here. It's not uncommon for us to leave the balloon up maybe for a minute or so. Now, while that is up, what we will do is we will bring the Sapien, the Sapien delivery system. So the important thing to remember is that the valve is mounted in the opposite direction, right? Because we are actually going into the mitral valve, we are going antegrade. And so it is very important that you ensure that you mount the valve on the balloon, not the way you do transfemoral TAVR, but in the opposite direction. Like in the old days, we would do transapical TAVR. Okay, all right. Okay, so I think this is reasonable, Mamu. What do you think? Yeah? Okay. Tarun, if you can. Yeah. All right. So we will go ahead and we will remove the balloon, and we can also remove. Okay. All right, Mamu, please walk this out if you want. Yeah. Okay, terrific.
I got a flush.
All right. So the important thing is, so let's look at the delivery system, and we'll point out a couple of important teaching points there.
I have the wire, Mama.
Okay, so you have the wire. Okay, so please bring the delivery system here. All right.
Raj, can you take the tension out?
Yes. Okay, so Mamu pointed out. See, this wire is very arrhythmogenic. All right, and it is. So, our wire is actually tickling and causing a lot of arrhythmia. Okay. All right. So I did pull it back a little bit, but I don't think we want to lose the wire.
Fair amount of
It's
support.
okay. All right. Okay. So yes. So we pulled it back, as Mamu aptly pointed out, because I think quite arrhythmogenic. So there is a little bit of, unlike the aorta, because you have to assemble this, all right, in the IVC. Now, so I don't know if you can see it, but essentially, can you point out? Okay, here.
So the
all right.
direction
So
is
the cuff is actually here on this side, not in the front. All right, because then when we go into the mitral valve, it's going to go down like this, and the cuff is going to be on the top, okay, the skirt. Now, the other important thing is when we introduce, we don't have the Edwards sign up, we have the Edwards sign down. Because you remember, when we do the TF procedure, when we flex it like this, the flexion occurs like this. But we want to go into the septum and into the left atrium, right? So we need to have the Edwards logo down. So when we flex, it looks towards the septum and towards the left atrium. All right. So I think those are important points to remember. All right. Now let's go ahead and load this up. Okay. The other important thing is that we don't have a lot of length to assemble this in the IVC because the sheath is long, right? And it reaches a lot of times almost the right atrium. Okay, so Tarun, go ahead and advance this, please.
Okay.
Okay, while Mamu is holding the wire. Okay, terrific. Okay, so we are coming up. So you can see here, what I like to do is we want to keep an eye on both the tip of the sheath and the wire there. Yeah, okay. All right, so we are coming out as you can see. All right, coming out, coming out, coming out. Now, what we don't want to do is we don't want to go with the tip of this catheter across the atrial septum. So what we will do is we will actually unsheath by pulling the sheath back. All right? Okay, can we make sure? You don't want to lose the LV wire because otherwise you have to start all over again. All right, and then we can see here, right, that we are out of the sheath. Okay, so we can go ahead and, yeah.
Can you try not to move the table?
Okay, go ahead. Go ahead. Advance and advancing so that you can, okay. All right, so you saw that, right? We had to pull the sheath out a little bit and then we can re-advance it. That's not a problem. Okay, now the other important thing is that we want to go and we want to deploy this valve in a coaxial view. So, as you can see now, are you able to see the three posts, right? Those three little holes you can see? Kentaro, are you able to see?
Yes.
Okay, all right. Yes,
Yes,
so
we can see.
we want for this to be coaxial, right? Because in this particular valve, we don't have the entire valve that we can see. We can only see the lower ends of the post, so we want to make them come in a straight line. And most of the times it's an RAO view or an RAO cranial view that we need to do. Okay, so now what we will do is, okay, let's go to lower mag and raise the table. Maybe that will help us. Okay. All right, so now we see the valve, we see the loop of the wire, and what we are doing is we are flexing as we are advancing. We are flexing as we are advancing. Okay, all right, good.
Through the septum.
So we are through the septum. We were, we were lucky that we did not hang up. Okay, now those posts that you see, those markers, are the lower end of the valve. All right, that's the lower end. Yep. So basically what we want to do is we want to line up the lower end of the valve here with those posts. And as we deploy, the force shortening will occur from the top. Okay. And, we debated here, according to the app, we need a 26 valve. We were tempted to consider using a 29 millimeter valve. So we have, the ID, the internal, though this is a 29 millimeter valve, surgical valve, the true ID is only 24. So, so we were debating whether we should use a 26 or a 29. You can use either. If you use a 29, I think in all likelihood, we would actually have some underfilled or underexpanded. So we have an extra 2 cc, so hopefully this will work out okay here. Okay. Huh? Yes. Okay. Okay, so Ben is reminding me to come back a little bit more with the pusher or the Retroflex catheter. All right. Okay, so I think that this looks reasonable, and we seem to be aligned okay with the lower part of the valve. Yeah. Okay, and then we can modify this, and the thing is, it doesn't look coaxial right now, but what we will do is we will go up slowly, and as we go up slowly, we will have the valve will have the opportunity to actually self-center. Okay, and it is always easier to push in than to pull back. So we can push the wire and we can come back. So that is another movement that we have available to us. Okay. Have we tested our pacemaker, guys?
We did, but we should test again.
Okay, can we test our pacemaker again, please? Please pace at 100. Saba, are you
Yep.
are you
Everything's
satisfied?
looking okay. Yes.
Okay. All right. Okay. Are we ready? Okay. Yes.
I didn't see consistent capture.
Oh, so you didn't see consistent capture. That's what I was told. Okay. So let's make sure, guys, that we are good at capturing. Otherwise, we may have trouble. Okay.
Can you test pacemaker one more time, please? Yes.
Maybe there are PVCs or
So are you on maximum output on the pacemaker?
Are you maximum output on the pacemaker? All right. Okay. All right. Are you ready at 180? Okay. Okay, Mamu. Are you ready? Everybody's ready? Sure. Okay. All right. Pacer on, please. Okay. Let's go up. Yeah. 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 Let's go up. Up, 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 up. Okay. Down. Off, please. All right. Okay.
All right, taking a look.
Okay. So fluoroscopically, we are good because the lower end of the valve is aligned with those posts. Okay. So, I think that when are you happy, guys? What do you think?
This is very good position.
Okay, so this position is good. The other thing that you are seeing here fluoroscopically is that the lower part of the valve is a little bit flared. Okay, so one of the things that we always worry about and account for is late migration of these valves. Okay, and
We're getting some arrhythmia.
okay, so we will go ahead. Let's go ahead and remove all of this. Okay, but before, a lot of times we'll park the balloon there just in case we have to post dilate. So, okay, so we'll do that. Now, Saba, tell us.
We're looking at the valve here. As you see, the valve landed really beautifully. There's no PV leak. There's a bit of valvular leak related to your wire. Yeah. So nothing that no problem I see there is going to go away once we remove everything.
Okay.
The valve looks to be well expanded on short axis, so we'll take a look at it by 3D.
Okay. All right. So it seems like that we can remove our system. All right.
Yeah.
So let's remove this system.
You can see here it's very circular.
We'll remove the system and replace it with the multi-purpose catheter.
It's a very circular valve on short axis, just a bit of valvular MR.
Yeah, and there is no PV leak.
No PV leak.
Because a lot of times, these surgical valves, they have both. They have valvular degeneration, but they also have a PV leak. And it may not become clear till you fix the valvular leak, We were doing a live case once for TCT, and we put a valve in valve, and then we noticed that there was a PV leak. Yeah. So we had to also go and plug that. So you can actually go ahead and do both of those procedures at the same time.
And I'm also looking at the LVOT to make sure that there's no, any obstruction, and it looks like there's laminar flow. I don't see any issues there. And then I don't see any gradient.
And Saba, can you look at the septum before we pull things out?
Sure, yes, let's do that.
Yeah,
so we had seen some earlier when you dilated, I had seen some predominantly left to right shunting.
All right, so, okay. So we don't like to pull the wire out. We like to straighten it out with the multi-purpose catheter.
So left to right shunting, I don't see any right to left right now.
So, okay, so you can see that, so let's go back to the valve now since we took out the wire.
Mm-hmm.
Okay, so it is in a much better state, so you can actually show us.
Hi, Raj. What is about the pressure gradient across the mitral valve?
What is the gradient across the mitral valve? We can go ahead and measure it actually. We will try to get that for you. Okay?
Just a change of
Check at a wire, we can cross the...
Yeah, so we will cross the aortic valve and we will pull this multi-purpose catheter into the left atrium, and we'll give you the gradient. But 26 valve is not a very big valve for a mitral, so I would not be surprised if the gradient is, it's not uncommon to see gradients of 5, 6, occasionally even 7,
So I get a gradient of 4, mean gradient of 4 and
Okay, so you got a gradient, so Sabah got a gradient of 4. Can you show us that, please?
Yes.
Raj, this is Keith Allen from St. Luke's, and
Hi,
really
Keith.
a nice case. You know, we're really aggressive with putting in large valves. You know, 23 and even a 26.
Can we get LVLA, please?
Are quite small, and I have to say we would have put a 29 in this and then fractured this valve with a 28 true.
Yeah, so I
fracture our mitrals.
Yes. Okay. So I think that with an EF of 20%, we thought it's possible that in future we might come and we might expand this a little bit. But you're right. If you had put a 29, we would have the luxury at a later point to come and be aggressive. So I think it's so sick right now that we wanted to go in steps. And
I will tell you that on our mitrals, we don't rapid pace when we fracture. So we don't actually rapid pace when we put the valve in. It's very different from, in our experience, doing valve-in-valve aortic. So I'm not as worried about pacing because we wouldn't pace.
Okay. All right. Good point. Okay.
So do you want to go through the valve now, Raj?
Yeah, sure.
I mean,
yes.
Now that everything is out, you're looking at the valve, you see really nice leaflet motion. There's really no PV leak. There's no valvular leak. If anything, there's like a little trivial jet there, but nothing significant. And that's going through the, inside the valve, probably from the skirt that's on the top. So really nothing there. The gradient looked good. I'm remeasuring it again. It looks really good. It's definitely not concerning. So even though you went with a 26 valve, it looks like the gradient is acceptable. And again, we looked for the LVOT. Again, there's no issues there. It looks all in all a very good result.
Okay. All right. Perfect. Okay. So I think what we like to do is we like to typically just monitor the flow across the septum. Because we've had cases where everything looked okay, and then, as the patient is coming off the table or whatever, you see that there's hypoxia and there is right to left shunt, and then we have to go and close the septum. So I think, so we'll do that for a little bit, but otherwise, the closure here is simple. This is just a venous stick. I think you could do this for straightforward valves. You could actually do this without TEE. You could just do this under fluoroscopy, right? I think so. And there is a lot of patients out there with bioprosthetic valves, both in aortic and in mitral position, that can be treated with a relatively easy procedure like this one.
Raj, you mentioned doing this without TEE, so you'd need the TE for your transeptal. You're not doing transeptals, just looking at
that's correct.
Bumps, are you?
Yes. So I think you can, you could use ICE. You could technically use ICE, and do a transeptal. But I think, we like to do this with, with TE. But you can do this, and I think there are people who actually do this without TE.
I think the IC is a little bit technically challenging, especially if you want to go for the side directive, like a very particularly like inferior, posterior, depend on the anatomy, depend on the vein. You may not be able to see precisely like where you need to go, and you don't want to puncture the wherever the tendon. That's not what we'd like to do for the mitral position.
Sure. I mean, I think there are plenty of people around the world, right? As we talk about disseminating this, there are so many patients with bioprosthetic valves, and we were showing a case when we were doing Africa, transmission to Africa. You know what I'm saying? I think the simpler you make it, I think the more applicable and more you can disseminate this. I think we happen to be at a center where we can get whatever we want, whenever we want, but there are practical considerations elsewhere. All right. So,
may I have a question?
Yes, please.
Actually, the congratulations on the great result of the and fantastic procedure, and I really learned a lot from your procedure. And I have a question. And actually for TAP in TAP procedure, we tend to deploy the valve a little bit lower compared to the previously implanted mosaic valve. And you deployed relatively higher compared to what we are doing TAP in TAP procedure. And do you have any rationale positioning of the TAP valve for the mitral position, mosaic valve?
Yeah, so I think in this case, LVOT was large, right? But I think often, especially when you're doing rings, that becomes a consideration, right? So LVOT. So I think that it's good to have, see, when you are working with a valve like this, you need to have some reference point. And when you line up with the lower part of the post or the marker as it is here, you know that things are going to be predictable, right? So I think, I don't see the rationale to go higher with valve in valve. Often with valve in rings, I will go higher for two reasons. Because I want to make sure that I'm able to anchor properly, right? Unlike the valve in valve where the anchoring occurs through the entire height of the valve, when you're doing a valve in ring, the anchoring is just on the ring, all right? And if you are low there, I get a little nervous and I say, you know what, let me be a little bit higher because I'll stay out of the LVOT and I know that I will anchor well. But the downside of going higher when you're doing a valve in a ring case, especially, is that you can have a PV leak. Or it used to be more common when we were using the S3 valve, okay, in a ring, which is still the case when you're using a 29 valve, but because of the skirt being not so tall, but with the Ultra, the skirt is taller, so you can still be a little bit higher and get away with proper anchoring and without leakage. So, I'm curious, Keith, do you think there are advantages or others on the panel of, in terms of hemodynamics or gradients, deploying this more atrially or otherwise?
No, Raj, I think your explanation was really good. These grommets, just for the audience that might be listening, those metal grommets on a mosaic are at the very top of the post. So if the bottom of the valve is here, these grommets are at the top of the post. So the way Raj lined that up is the way we do it. We put the top of the S3 at those grommets and it foreshortens from the skirt up and it usually will land very nicely. We really try to land at in our mitrals, particularly quite high, or ventricularly if the LVOT is not a problem, because the higher you are or the more ventricular you are, the less chance you're going to have a gradient, particularly if you're not fracturing the valve and making that S3 perfectly expanded when it's fractured. So low implants lead to high gradients or higher gradients, and that can be a real killer in a mitral.
Yeah. All right, so is our patient saturating well? There is no right to left shunt?
No, I just checked. There is no right to left.
Okay, so do you feel comfortable? We'll just go ahead and close the groin then. Okay?
Yeah.
All right. Okay, so we'll go ahead and let's go ahead and close the groin. Okay. All right, Arvind, you want to just come here? Okay, terrific. So, if there are no other questions, we are happy to sign off. If you have anything else to discuss, we are happy to talk.
How much oxygen?
Professor Wang?
Go ahead.
Oxygen.
Hi, Raj.
Yes.
It is not necessary to close the...
Can you give protamine, please?
Yeah, sure. Some device. Unnecessary to close the transcatheter hole.
Oh, you're talking about close the ASD, close the ASD?
Yes, yes.
Yeah, so it is not necessary. It is not necessary. I think, so in the early days, we used to close it in everybody. Then we realized that we didn't really need to. And of course, I would say that, you know, right, there was a trial, there was a randomized trial, right, after MitraClip. I forget the name of the study, where in some patients they left it open, or in some patients they left it closed, and there was no difference in outcomes. But I think that this should be driven by what happens to the shunting. So I think we have had patients where the tricuspid regurg was massive, and we had right to left shunting. So there it makes sense to go ahead and close it. Because, you know, in the future, in the future, we want to go back in the future and do another valve-in-valve, maybe fracture at this time, and then, you know what I'm saying? So I think down the road, he may require more work. So not that we cannot do it. You know, we can puncture these devices and go across, but I think if you can avoid it, it's a reasonable thing. Go ahead and do it.
Okay, thank you, Raj, and your wonderful team. Because of time limitation, thank you again for your two wonderful live demo procedures. So one is a very tough case about TAVR in patients with severe calcification and bicuspid aortic valve diagnosis. The second one is a so challenging case. It's actually valve-in-valve procedure by transeptal way. You are doing so well. Congratulations.
Thank you.
So
and
that's all for today's live demo. TCTAP 2022. Thank you all. Looking forward to see more procedures you show us. Okay.
Thank you.
Bye-bye.
Congratulations.
Thank you.
Bye. Great case.
I want to thank once again the organizers and all our staff here who are always very excited to do live transmissions. So thank you.
Thank you.
Thank you a lot.
Bye.